A very warm welcome to all of you. So today I'm going to be taking a lecture on post-endodontic restorations. This is going to be a two-part lecture, and in the first, that is today, I will be explaining the role of the restorations in increasing the longevity of endodontically treated teeth, and when you decide, when do you think a tooth is indicated for post and core, when a restoration should suffice, or when you give a vital crown prep. And I'm going to be outlining the indications and contraindications for post placement both in anterior and posterior teeth. I'll also be giving a brief classification on how you can classify your different post systems, and in the next lecture I will be talking about their advantages, disadvantages, and the different kind of core materials which will be used to restore the endodontically treated teeth, along with the explanation about the different post system. So why is restoration of an endodontically treated tooth important? So basically, once you remove the soft tissue of the tooth, that is the pulp, your tooth actually becomes brittle. So it's the easiest way which I can actually explain the condition of the tooth is like it's going to be like glass. So what happens when you throw a rock or a stone at glass? It tends to crack or break. So the concept of an endodontically treated tooth is very very similar to that, and so we have to actually protect the tooth which is endodontically treated. So to protect it, you have to restore the tooth with a composite restorative material, and then you need to depending upon the amount of loss of tooth structure before the commencement of your endodontic treatment, we need to decide whether a post and core is required, followed by your prosthesis, that is your crown. So I will be explaining in the future slides on how to decide as to which kind of treatment has to go for what, and there are various kinds of post endodontic treatment. So you can the different type of post systems are there. So basically they are broadly categorized into the prefabricated, that is the most commonly used nowadays is the fiber post system, and the custom made, that is your cast metal post and core, which is a single unit. So these are the broad classifications of your post and core systems, and I will be talking about it in the future. So what are the two main reasons why we require to address your endodontically treated teeth and why we need to restore them? So you have your functional requirement as well as your aesthetic requirements. So when it comes to the functional requirement, we know that the loss of tooth structure is mainly or primarily due to caries or fracture. So that is your trauma. And the third is because of what we do to actually endodontically treat the tooth. So you are actually making the tooth hollow from within when you are doing your access cavity preparation. So you have to understand that if a tooth was subject to trauma and it has lost maybe 30 to 40% of the tooth structure from the outside, and then you're going to treat it endodontically and you're going to be doing your access cavity prep and your cleaning and shaping, your tooth is becoming weaker from the inside as well, because you are removing significant amount of healthy tooth structure. So all these factors play a role in deciding whether you have to go ahead with a post and core or not. Whereas the aesthetic requirements, now you're living in the 21st century, aesthetics plays a very very important role in the dental market. So a lot of patients, they walk up to you with discolored teeth or a totally dark tooth, and then you have to decide whether you want to do a simple bleaching or whether you have to actually treat it because it's non-vital, and following your treatment, endodontic treatment, that is your root canal. Do you actually go ahead with post and core, or do you have to go ahead with a crown, or will a veneer suffice, and so on and so forth? Yeah. So that is one that could be one reason. The darkening of the tooth is because of one of the reasons for darkening of the tooth could be because you have left behind vital pulp tissue which is degrading inside the pulp chamber. So this very commonly happens when you have not de-roofed the pulp chamber, especially when it comes to the anteriors. Like for example, the maxillary center incisor, it has three pulp horns: the mesial, the central, and the distal. So generally, when private practitioners, they try to do a conservative access opening, sometimes when you are inexperienced, you tend to not extend your access cavity prep to include the mesial and the distal pulp horns, because of which you are actually leaving behind vital pulp tissue, which will degrade in the future, and the breakdown of the pulp into hemoglobin, the hemoglobin components, is going to cause the discoloration of the tooth. That happens slowly over a period of time. So then one fine day, the patient whom you treated a long time back is going to come back and say, "Doc, what's happened to my tooth? I mean, I thought you treated it endodontically, and now I can see that it is totally discolored. Is something wrong?" So the patient wouldn't be aware of what has happened, and you may not remember that you had actually treated the patient for an endodontic treatment, and then you would be like, totally clueless. So this could be one primary reason. The second is when you place certain medicaments in the pulp chamber. So in case if you have heard of the triple antibiotic paste, so sometimes we use doxycycline, sometimes we even powder metronidazole and place it inside the pulp chamber as an intracanal medicament in cases of long-standing lesions, which are not healing with the primary intracanal medicament, that is your calcium hydroxide. You see that there is a continuous draining sinus, and the abscess is not healing, the periapical lesion is not disappearing, the patient is totally symptomatic, even after placing your calcium hydroxide for a couple of weeks. So then you decide to switch over to a more potent or more powerful intracanal medicament. So in the cases of using doxycycline and your metronidazole, there is a chance that your tooth becomes discolored. So that is another reason. And then of course your sealer and gutta percha is left behind in the pulp chamber. So when you are actually shearing off your GP and after your endodontic treatment, if you don't shear it off at the level of the CEJ and you leave behind the gutta percha and root canal sealer in the pulp chamber and in the crown, which reflects in the crown, in the crown of the tooth, in the coronal structure of the tooth. So later on, if you don't give a crown to the patient and you just do a normal composite restoration, this gutta percha and sealer is going to cause discoloration, which is going to reflect through the enamel of the tooth. So that contributes to discoloration as well. Coming to the indications of post and core. So the primary indication, this is one thing which we have to understand. A post and core does not strengthen the tooth. The post and core actually causes weakening of the tooth from inside, especially the root surface. So you have to actually decide whether you are going to give a post and core. It is not given to strengthen the tooth, but it is only given to retain the core and to give additional retention for the prosthesis which you are going to place, that is the crown portion. So please try and understand, if you are performing a post and core, 110% you have to give a crown as well. You cannot do a post and core and not give a prosthesis, okay? Because that tooth which was already weak because of the endodontic treatment has become weakened further because of the post and core, and now you're going to leave it without protection. That's like riding a bike without wearing a helmet. Yeah, so you're just asking for trouble, okay? And then when you have a crown which is susceptible to cervical fracture, cervical crown or a root fracture, then you can indicate, it can be an indication for a post and core. A grossly discolored tooth in which more than 50% of the tooth structure is missing, in this case definitely yes, we do like to give post and cores. Loss of both the proximal surfaces. So let us assume that you are dealing with a molar or a premolar, and you have lost your mesial and your distal marginal ridges. The tooth has lost more than 40 to 60% of the strength, the original strength which the tooth would have had, because of which yes, you definitely require post and core so that you can actually retain the crown in place. Yeah, so yeah. And then if you have a shortened tooth with insufficient retention, so that means you don't have enough structure to actually place the crown on, so then yes, you do need to do an endodontic build-up, that is a core build-up, and to retain that core in place, you might have to you might have to advise a post and core system. And the same applies for a vital tooth with insufficient retention for a conventional crown. So the last 2 points are quite similar. So in the cases where you actually want to give a crown for a vital tooth which is actually very small, in those cases you might have to endodontically treat it and actually increase the size of the coronal portion by actually doing a core build-up so that you can actually retain the crown in place which you want to give. What are the contraindications for your post and core? The first one is severe curvature of the root. So you have to understand that your posts, whether it be your prefabricated fiber post or whether it be your custom made cast metal post, they are not flexible. So they cannot adapt to the curved canals of the root. So in such cases, if there is severe curvature which begins right at the cervical third, which is rare though, but I mean, if it begins right at the junction of the cervical and the middle third, in such cases giving a post is out of the question, because your post will not be able to adapt to the curved canals of the root. You can never ever give a post and core in a tooth which has a persistent periapical lesion. So in such cases you have to make sure that you resolve the periapical lesion only after you have healthy bone support and the tooth is asymptomatic. Only after that can you actually proceed with your post and core. Okay, so if you have done an obturation and there is a periapical lesion, you have to still wait and watch. Wait until the lesion disappears and resolves itself and you have healthy bone support. Only after that you can do your post and core, because removal of posts is quite tricky and it's not it's not really advisable. Also, when you are removing your gutta percha and root canal sealer, you have to understand that the post is not antibacterial, so it does not have the potential to actually ward or fight off your bacterial or microbial infections. So you are actually creating the tooth to be more susceptible to infection again. So you have to make sure that you have resolved any long-standing infections in the beginning itself. If the tooth does not have sufficient PDL support, if the tooth is mobile, we do not suggest to go ahead with post and core. We first try to improve the stability of the tooth. Probably you can go ahead with periodontal therapy followed by splinting. Observe for 2 weeks. If you are able to resolve this and then the tooth is no longer mobile, then yes, you can go ahead with your post and core. If you have poor crown root ratio, so in the teeth which have very short roots, we do not suggest post and cores, because you need to have significant amount of root length, which will be discussed in the later slides. Weak or fragile roots, like in the cases where you have internal or external resorption, or the root itself is weak, there is an apical root fracture. In such cases, we do not give or advise your post and cores. Heavy occlusal contacts, if you have an edge-to-edge bite or a deep bite, we do not advise a post and core, because the forces are going to be transmitted directly to the post and the core, and that could lead to a horizontal or even a vertical fracture of the weakened root structure because of the post. So in such cases we do not advise it. So you always have to check the occlusion of the patient as well. Now coming to the treatment planning for the restoration of your non-vital teeth. So you have to decide on what kind of treatment it is, and the factors which come into role and which play on this treatment planning are: first is the amount of remaining tooth structure. So you need to judge. Please remember, if you have more than 50% of tooth structure, you can go ahead with your normal restoration followed by a crown. Yeah, and if you have lesser than 50% of tooth structure, then you got to decide whether you want your custom made post or whether you require your fiber post. Okay, the anatomic position of the tooth, is it an anterior, is it a premolar, is it a molar, is it buccally placed, is it palatally placed? All of these play a role in deciding whether you have to advise a post and core or not, along with of course the amount of remaining tooth structure. So it is a multifactorial decision which comes into play. The functional load on the tooth, this is what I was talking about in the previous slide. So if you have an edge-to-edge bite or a traumatic occlusion, in such cases you have to decide against giving a post and core, and you have to think of the next best, most suitable treatment. Coming to the restorative requirements of the tooth, does the tooth actually require a post and core? Do you think that the core will be able to retain itself in the crown structure of the remaining crown structure of the tooth without the post? Does it require it? Is the core buildup required? If the core buildup is required, can it be done without the help of a post, or does the post play a role in such cases? All that has to be decided, and of course your aesthetic requirements as well. So if the tooth is totally discolored but it is intact, can normal bleaching be sufficient after your endodontic therapy, or can I just give a veneer? So all these have to be considered as well. So this is the misconception which a lot of people have, because previously it was considered that the post and core actually provides reinforcement to the root. But now it has been proven and it has been shown by numerous researches which have been conducted that it actually only may reinforce the remaining coronal tooth structure, but it will significantly weaken the root. Yeah, so you have to keep this in mind when you are advising a post and core to a patient. So if a crown is not required for aesthetic or functional reasons, then it is generally considered unnecessary to place a post. Okay. Now coming to the anterior teeth, this is what I was talking about. If you have an intact discolored tooth without any loss of tooth structure, probably after your endodontic treatment you can just prescribe your walking bleach technique, or your in-office, you can use your thermo sensitive bleach, and then or you can go ahead with your veneers. However, if you have loss of tooth structure but the remaining tooth structure is more than 50%, if it is discolored, you do your endodontic buildup, and of course you have to give a full coverage crown. If the remaining tooth structure is more than 50% but it is not discolored, a composite restoration should suffice for time being. Yeah. Now coming to the decision of your post and core, when you think it is required and what kind of post is required. So if you have a tooth in which the remaining crown structure is between 25 to 50%, in such cases you can give a non-rigid post and core along with the crown. So the non-rigid post is nothing but your prefabricated fiber posts, whereas when you have a tooth which has undergone significant amount of trauma or caries decay, because of which the remaining tooth structure is less than 25%, in such cases when the patient still wants to save the tooth, you have to think along the lines of your rigid post and core, that is your single unit cast metal post and core along with the. And when it comes to posterior teeth, please understand, when you are doing endodontic therapy for a posterior tooth, whether it be a premolar or a molar, 110% all cases cusp capping is required. So in all your posterior teeth, if you perform your root canal treatment, you have to cap all the cusps because of the amount of functional load these teeth are subjected to. The premolars can be very tricky because they come right in between the anteriors and the molars, and they are subject to the forces which are subject to the anteriors as well as the posteriors as well. So they're getting the best of both worlds. So in the cases of premolars, you will generally see immediately after your endodontic therapy, if you do not prescribe a crown, very soon the patient is going to walk back with a fractured tooth, and unfortunately it might result in the removal of that tooth if you are not able to salvage the loss. Yeah. So the most conservative tooth involvement you can do for your posterior teeth is to give a cast metal onlay, wherein you have actually capped all the cusps of the posterior tooth. However, if you have this can be done only when you have a class 1 access opening, and you do not think that you want to give a crown, so because you have sufficient amount of healthy tooth structure. So in such cases you can give a cast metal onlay. However, if you do a class 1 opening and just restore it with composite, just to restore the access cavity which you have created, it is not going to suffice. So the minimum you can do is give a cast metal onlay to protect the tooth. If you have a tooth where the remaining tooth structure is more than 50%, you can just do your normal build-up, that is your core build-up without the post, and then give a crown. But if the remaining tooth structure is less than 50%, you have to give a post which is going to be helping to retain the core within the remaining tooth structure, followed by your prosthesis, that is your crown. So please try and understand, wherever you have your posterior teeth and you require to give a post and core, the post is always given in the widest canal. So in the cases of your maxillary teeth, it is always placed in the palatal canal, and in the cases of your mandibular teeth, it is always placed in the distal canal. So if you have two distal canals, you can place it either in the distobuccal or the distolingual. So you always place it in the widest possible canal. Okay, so what exactly is a post? It is a rigid restorative material which is placed in the root of an endodontically treated tooth. Please, folks, please remember, you cannot place a post only after this thing, what do you say, cleaning and shaping. You have to do the obturation, and only then you can place a post. It is a very sad and sorry state, but I have seen a lot of cases where, you know, the patients have gone to the dentist has initiated root canal treatment, and instead of actually filling up the canal with gutta percha, he has just placed a post, you know. And the post, of course, it'll be present only in the cervical and the middle thirds of the root, but then the apex is like totally empty. And you know, the post also, because it's a tapering kind of a post, there's going to be a gap between the post and the wall of the dentine, so all this area is going to be reinfected, and you know, the patient is going to walk in with reinfected tooth. And then the real headache starts, because how do you remove the post? Removing the post is not very easy, so you know, you have to actually question the prognosis of the tooth and then take a call. So the most effective way you can think of in your private practice to actually remove a post is to use your ultrasonics. So you place the ultrasonic tip, that is your ultrasonic endodontic tip, because it's thin. You place it at the junction of the post and the dentinal wall, and when with the vibrations of the ultrasonic tip, you are actually trying to break or create micro cracks in the junction of the sealant, which is the sealant which is used to seal the or lute the post into the canal. So once that breaks, then it is a little easier to dislodge the post from within the canal. However, it is easier said than done, and it may not work all the time. Yeah, so that is why you have to make sure that your tooth is absolutely healthy before you actually lute a post into the canal. And the function of the post is it directs the occlusal and lateral forces apically. That is why we wish to have the apical seal of GP, gutta percha, in a flat state. We don't want after the removal of the gutta percha, we don't want there to be an uneven you know, apical seal. That is, there is at the 3 to 5 apical seal mark, we want a flat base of gutta percha, so that your forces, when they are directed apically, it will be uniformly transmitted. Now, coming to the historical background, when did this start? The restoration of endodontically treated teeth have been in the market for more than 250 years now. So a lot of people, even Pierre Fauchard, considered as the father of modern dentistry. Even in you know, the early 1700s, he had described the use of tenons, which were actually metal posts which were screwed into the roots of the teeth to retain the bridges. And in the 1800s, wood had replaced the metal, probably because they felt that the metal was actually, you know, weakening the tooth from within, so they would have tried to replace it with wood. The problem with wood being that wood absorbs moisture and swells up, and that causes fracture of the roots of the teeth. Ironically, it is because of this very feature that we prefer to use wooden wedges when we are using our matrix bands, because the wood actually absorbs the saliva and it expands, and it actually gives a better seal in that area, you know, and better retention to the matrix band which you have placed in the interproximal area. That is why they got rid of the wooden posts. And then later on, in the late 19th century, the Richmond crown came into place, came into being. That is a single unit post, core and crown. So that means your post is merged to the core, and the post and core together is merged to the crown as well. That is your prosthesis. So it is a single unit prosthesis with a porcelain facing for aesthetic reasons, and that had become popular in the market. And then, of course, the early 1900s, we came up with the custom made cast post and core. So these are very, very good for the cases where you have, you know, less than 25% of tooth structure. So to actually help retain the crown, you need a stronger kind of a post and core system. So you can think of the custom made cast post and core. And so in this case, in these cases, the custom made cast post and core, you have to fabricate the post and core separately and the crown separately, so it's not a single unit. However, the post and core is one single unit. Yes. So now, this is the main question. Do all endodontically treated teeth require a post? The answer is no. You have to give the post only when the remaining tooth structure is less than 50%. So if your remaining tooth structure is more than 50%, a normal core buildup and crown should suffice. But if it is less than 50%, yes, you can give a post and a core by your crown. Now, this is the classification of the posts on a very broad basis. So, the main one is what I had told you in the beginning. You have your prefabricated, your fiber posts, wherein the post is separate, the core also is built up separately, and then of course you have to give the crown. And the beauty of this is that the post which is luted in and the core which is built up will actually act as one unit, because it's all the resin, the fiber reinforced resin post and core, so they actually bond together and they actually function as a single unit. So it's quite convenient, also it saves time also, and it serves the purpose as well. But however, we prefer to give it only in cases where you have at least 25 or 30 to 50% of the remaining tooth structure. For lesser than that, we still have to go ahead with your custom made cast post and core, which of course requires multiple visits, because you cannot manufacture it in the first day. A lot of laboratory work has to be done, wherein you have to do the casting and you actually have to fabricate it in the laboratory. Then we have the metallic and the non-metallic posts. In the olden days, we used to get screws, the metal post screws also. And of course, your custom-made cast post is also a metallic post. The non-metallic, the best example is your prefabricated fiber post. The rigid and the non-rigid, again, your rigid post will be your custom-made cast post, and your non-rigid is your prefabricated fiber post. You also have different other kinds of materials. You have your carbon posts and you have your zirconia posts and all. But after a lot of research, it has been seen that the prefabricated fiber post is still the best when compared to all the others. The zirconia posts and the carbon posts, although they may have increased strength, they do tend to cause more harm than good, either in the form of root fracture or debonding and so on and so forth. The aesthetic and the non-aesthetic posts, it's very clear which is the aesthetic. It is the fiber posts, and the non-aesthetics, of course, the metal posts. So this happens especially when you are giving your when you decide to give an all ceramic or a zirconia crown. You cannot give a custom-made fiber cast post, because sorry, a custom-made cast metal post, because the cast metal will actually show through or reflect through the zirconia crown or the all ceramic crown. So in such cases, you have to go for your fiber post as well. So if you give a fiber post and then you give your zirconia crown or your all ceram crown, then it makes sense. Yeah. Then you have your active and passive posts. Please try and understand, we no longer use active posts, because the active posts possessed screws and threads which were used to engage actively into the walls of the dentine, but they were found to have caused a lot of micro cracks, and they lead to fractures, and it was also not very easy to remove these active posts. Of course, they do have the tools by which you can unscrew the posts, but it is no doubt not very easy. So generally what they do is, to retain these active posts, they take the post which is one size larger than the diameter of the diameter of the root canal. And because of the elastic nature of the dentine, the root actually expands to accept the post, and then it is actually screwed in tightly. So that actually generates a lot of stress inside the root system of the tooth, which led to a lot of horizontal or even vertical split fractures. And based on the shape, you can have your parallel posts, your tapered posts, and the combination of your parallel and tapered. So your parallel post would be the post which is in which the borders of the post are parallel to each other from the top till the beginning. Okay. The tapered posts are those which actually taper like the root canal system of like how we have the root canal systems of your natural teeth. And what I feel is the best one is the combination of the parallel and the tapered, wherein 90% of the post is actually parallel to each other and the last bit is tapered. This is just done to mimic the root canal system in which you are going to be placing the tooth. So in which you are going to be placing the post, sorry, because if you would have noticed, your root canals are wider at the cervical and the middle, and they are actually tapered and narrower towards the apical third of the root. So this parallel and tapered combination is actually done to actually have a snug fit for the tapered canals. Coming to the factors which determine the post selection. So when it comes to the root length, so if you have your long rooted teeth, you can place a post which conforms to at least 3/4 of the length of the root. So you don't actually have to go to all the way just to get just to leave behind 5 mm of apical seal. It's sufficient that at least 3/4 of the root length is supported by the post in such cases for the long rooted teeth. Whereas if you have only an average root length, please try to maintain at least 5 mm of apical seal. The remaining portion can be kept for the post. Yeah, and for the very short roots, the root lengths, you have to sacrifice on your apical seal, and from 5 you can actually go down to the minimum, the bare minimum of 3 mm. So anything below 3 mm is not going to be giving you a very good or decent apical seal. So please keep in mind the apical seal can vary from 3 to 5 for your short to average root lengths, and for your long rooted length, of course you can have more than 5 mm of your apical seal also, because your root can afford to give you more than 5 mm of your apical seal as well. Earlier days the concept used to be that the post length should be at least, in the bare minimum cases, should be at least equal to the length of the clinical crown. That is no longer the case. We generally like to have a longer post inside the root canal system. And for the molar posts, it should not be extended more than 7 mm into the root canal apical to the base of the pulp chamber. This is because generally we have seen that in the molar teeth the roots can be quite curved, or there can be variations in the root canal after this 7 mm length. So that is the apical third of the root canal system. So in such cases we do not want to have the post extending beyond 7 mm. So the reason why this 5 mm, 3 to 5 mm of apical seal was actually considered is because it has been seen in numerous studies that 95 to 98% of your anastomosis are found in the apical third of the root canals. So that is your lateral accessory canals, your fins, your apical deltas. They are all seen in the apical 1/3 of the root canals. So if you have gutta percha which is sealing that area, because your post and core system is not antibacterial, you do not want to leave your anastomosis, that is your accessory canals, your fins, your apical deltas and all, exposed to the oral environment or exposed to the chance of micro leakage and subsequent reinfection. That is why the golden rule is to have at least 3 to 5 mm of seal. So this is what I was talking about. 3 mm of remaining GP gutta percha is the absolute minimum, and 5 mm should be left in as many cases as possible. Yeah. So what about the post diameter? Now there are various schools of thought. You have different types of theories. The conservationist theory, the preservationist theory, the proportionist theories. Basically what all these people had in mind is that you should try to conserve the tooth from within as much as possible. So do not enlarge the post space so much that you are actually creating a hollow tooth from within. So earlier days they even suggested that the canal should not be further enlarged after your cleaning and shaping and obturation, but your post should be modified to actually fit that canal. But that doesn't make sense, because you actually want to prepare the post space also. That is why we have our piezo reamers and the dedicated post drills, which now come with your prefabricated post systems. So what we do is we generally prefer to choose the smallest drill, and then we proceed to as much as the size is required. So in very large canals, of course the smallest post is not suitable, because we want a snug fit into the root canal system. So if there are very wide canals, we prepare the the root canal with the necessary post drills according to the diameter of the canal. So that is the case on how you decide how much of the post diameter is required. So for narrow canals, you probably use only the first drill and then you place the thinnest post possible. And of course, you keep going higher up according to the diameter of your root canals. So in the wider canals, you place your wider posts, and that's how it's done. So this was it for today's lecture. In the next lecture, I will be talking about the different kind of post systems and their advantages, and the different kind of core materials also which can be used to build up the crown structure. I hope you were able to gain some insight into the post endodontic restorations lecture. If you have any doubts, please feel free to contact me. I'm always there to help you guys out. So until then, stay safe and take care, guys.